Hello, ladies and gentlemen. I am Dr. Jeff Maccullough, the Emeritus Professor from the University of Minnesota in the U.S. And I am delighted to have with us this morning Dr. Dolores Villarino. She works in the University Clinic Hospital of Santiago de Compostela, one of the largest hospitals in the region of Galicia. She's been working there as a hematologist since 2013. In 2008, the Agencia de Sangre de Tejidos, the regional blood center in charge of collection of blood in the Galicia region, implemented the Intercept technology for pathogen reduction of platelets. By 2016, there was a change in technology, and the Mirasol technology was implemented. And this is still the routine process for preparing platelets for transfusion. Dr. Villarino has extensive experience in hematology and with the clinical use of these Mirasol platelets. So we're delighted that you can join us today, Dr. Villarino, to discuss your experience. How long have you been involved in the use of Mirasol platelets?
We implement the Mirasol platelets in 2016.
Have you noticed any differences in the patient's response to platelet transfusion? Have there been any unusual bleeding problems or anything different with the patient's reaction to the platelets?
The reaction of the transfusion reaction is not different from other kinds of technology of inactivated platelets.
Have you noticed whether more platelets are needed? It's one of the concerns that always comes up is whether with the pathogen-reduced platelets more transfusions will be necessary. Have you noticed this?
No, we didn't notice that aspect in our routine.
Well, this extensive experience must have involved quite a few patients. Do you have any approximate idea of the number of patients that have been involved? And can you tell us a little bit about those patients? What kinds of patients were they?
We have extensive experience with the different kinds of patients. The number is very large, maybe more than 500 in the last years. And most of these patients have hematologic malignancies. Maybe the most frequent is the lymphoma or the transplant bone marrow transplantation. However, we have some kind of experience of different kind of patient. For example, the patient from surgery. In the surgery area, we have the cardiac surgery. That is the most frequent kind of patient. We need the transfusion of platelets.
Mm-hmm. So this is extensive experience. It sounds as if you're saying, first of all, more than 500 patients. Many of these are bone marrow transplant patients. I assume also hematologic malignancies receiving chemotherapy. But also the interesting part is cardiac surgery patients as well. Well, and the most important aspect of all this is, has there been any difference in bleeding with the patients receiving the Mirasol platelets?
There is no difference between the Mirasol platelets if compared with other kinds of PRT platelets. It's no difference.
Now I have a specific question about irradiation. I assume many of these patients are susceptible to transfusion-related graft versus host disease. Do you irradiate the Mirasol platelets in order to avoid that potential problem?
No, in our we don't have experience with the transfusion of irradiated platelets because all of the platelets are inactivated.
So you're confident that the pathogen reduction technology damages the lymphocytes sufficiently that irradiation is not required. Is that?
Yes.
Okay. So the main difference is the configuration of the container and the way the nurses would enter the container when they're giving the transfusions. Well, in relation to the advantages of pathogen-reduced platelets, this seems like a relatively simple thing to retrain the nurses. Have they been able to deal with this satisfactorily?
Yeah, yes, it was very easier to introduce this kind of platelets because nowadays all of our nurses feel confident to use this kind of container, and we don't have any kind of problems in the clinical area to do the transfusion, follow the normal protocol of transfusion.
Well, this has been very helpful, Dr. Villarina, and I appreciate your taking your time to talk with us today. Very best wishes to you. Well, hello, and I'm excited to next introduce Dr. Elizabeth Brucey. She's a hematologist and serves as head of the transfusion service and clinical hemostasis unit at the St. Savas Oncology Hospital of Athens, Greece, which has a huge oncology department, a hematology department, hemovigilance, stem cell transplantation. And she's been active for many years, and we're delighted that she can join us today for this conversation. So let me begin by asking Dr. Brucey about how long that you have been involved in using Mirasol platelets.
Thank you very much, Professor Mackallow, for your kind introduction. I would like to say that it's both a pleasure and honor having this discussion with you. I have been using Mirasol for pathogen inactivation in platelets apheresis for about 6 years, and recently we started using this technology for pathogen inactivation in plasma, mainly trying to create a stock of AB group plasma for therapeutic apheresis.
Oh, wonderful.
Yes.
So about 6 years, that's quite a nice experience. You have a very large, very active center. Do you have any approximate idea of the number of patients that might have received the Mirasol platelets?
Okay. We have transfused about more than 2,000 patients. The majority of them, over 95%, are immunocompromised patients with hematologic malignancies and solid tumor. We began the implementation of the Mirasol system in September 2015. Since then, we have processed and transfused about 3,000 units of platelet apheresis out of a total of 3,500 units produced.
Wow, that's a wonderful experience. You mentioned that many of the patients, most of the patients, are immunocompromised. Do you irradiate the Mirasol platelets, or are you comfortable that they will avoid causing graft versus host disease without gamma irradiation?
For me, this is a big advantage because we do not irradiate Mirasol platelets. As I said before, our hospital has a hematopoietic stem cell transplantation unit, so there is a need for irradiated platelets. Pathogen inactivation techniques appears effective against proliferative of white blood cells and T lymphocytes, so they can be an alternative practice to gamma irradiation to prevent transfusion-associated graft versus host disease. Hemovigilance data from different countries have shown no cases of transfusion-associated graft versus host disease after a huge number of transfusion of Mirasol-treated patients. That being so, the Council of Europe suggests pathogen inactivation technique as an alternative to gamma irradiation. And in our department as well, we follow this practice.
And I assume that you have not seen any situations of transfusion-associated graft versus host disease.
No, we didn't have any case of transfusion-associated graft versus host disease.
Well, from this very extensive experience, have you noticed any changes in platelet transfusion practice? Do you need to use more platelets or transfuse patients differently?
No, there hasn't been any change in our transfusion practice. They were not adverse reaction associated with the transfusion of these products, or at least there weren't any more than we had following the transfusion of platelets not treated with riboflavin.
Have you noticed any differences in bleeding with your patients?
This, of course, is the effect of how effective is the product. I could say that we didn't have any change or any difference in the transfusion of red blood cell in the case of bleeding. The products are the same effective as before in the cases of bleeding. My impression is that we didn't transfuse more red blood cells than before. Of course, it could be better if we can estimate it with randomized trial, but it is very difficult to design and conduct such a study.
Yes, it is, isn't it? Do you have any advice for any other physicians who might be considering the use of Mirasol platelets?
My advice is that the use of Mirasol is very practical, safe, of course, provide an additional safety of blood transfusion. And I believe that, I hope that maybe this will be soon possible for red blood cells. I think that if it will be possible for red blood cells, it will completely transform the landscape in the chemotherapy.
Yes. Doesn't this seem as if this is the central part of blood safety for the future?
Yes.
Yeah. Hello again. I'm delighted to be able to be here again today with Dr. Sigrid de Velde. Sigrid has been working since 2006 in Hematology Oncology Department at Luxembourg Hospital Center. She's a principal investigator on several studies in hematology and is the author of chapters and books and several articles in recent years. She deals with the hematologic malignancies and benign hematologic conditions. She also has responsibility for the apheresis center. So it sounds, Sigrid, as if you have many, many responsibilities that must keep you quite busy. So let me start by asking you how long you have been involved in the use of Mirasol platelets.
Already more than 14 years.
My gosh, 14 years, did you say?
Yeah, from the beginning with Krugl's study.
So that must be almost from the beginning of when Mirasol was available.
Yeah,
So
at that time, we also did the procedure here in our unit. After a couple of years in Luxembourg, they decided that it was only the Red Cross who would do the procedures. So it has changed to the Red Cross, but before it was locally produced here in the unit itself, in the hematology unit.
So that's a very extensive experience. Do you have any idea approximately how many patients might have received the Mirasol platelets?
A lot. Because in the beginning, it were only our leukemia patients that were treated with the locally treated platelets. But now it's overall used in Luxembourg, so all platelet transfusions are treated. So even oncology patients, even lymphoma patients, everyone receives the Mirasol treated platelets now. So
all platelet transfusions are Mirasol platelets?
Yeah.
And you may have said this, does this include for instance, cardiac surgery patients or other kinds of things? Huh?
Yeah.
My gosh, what an impressive amount of experience. With all of this experience, have you noticed any differences in the patients, any differences in bleeding or differences in the number of transfusions you need to give?
Well, this is difficult if you don't do really the statistics to have the numbers. So on the numbers of transfusions, I think it's the same. It's more the tolerance that is a lot different, because 15 years ago we had a lot of patients who had chronically pre-medication before platelet transfusion. Now it's really very rare, the patient that has to receive pre-medication. And I think for the last 5 years, we only had 3 patients where we have to give plasmatized platelets because of reactions even with Mirasol and with pre-medication. So, but it's very, very rare. But the patients that do receive a pre-medication, that were really patients with an hematological disease and palliative care who had already received twice a week platelet transfusions for months or years, and so voilà.
My gosh, it sounds as if transfusion reactions have almost been eliminated.
Mm-hmm.
Wow. And let me ask you again about bleeding. Are you aware of any differences in the bleeding experience with patients? Is there any more bleeding since you started using Mirasol platelets?
We don't have a lot of bleedings. It's rather rare. Maybe this is because we have easily access to transfusions. Even patients who are living on very low platelet count for months, we do transfusions regularly at the day hospital. So the bleedings they're very well controlled. I think we had one cerebral hemorrhage the last couple of years. Sometimes hemoptysis for people with pneumonia. Some bleeding with myositis, but no major bleedings.
This doesn't sound any different than the kinds of bleeding you might expect from these kinds of patients.
Mm-hmm, mm-hmm.
Okay. Let me ask you a different topic. The kinds of patients you're dealing with, many of them would be susceptible to transfusion-associated graft versus host disease. Do you irradiate Mirasol platelets to prevent that?
No. We never do. For transplanted patients, we just give the Mirasol-treated platelets, and we never have been irradiated complementary to the Mirasol.
So
we
you
never saw a problem with the transplanted patients now.
Wonderful. So you're comfortable with the effect of the Mirasol treatment eliminating the risk of graft versus host? Mm-hmm. Well, my last question for you, Sigrid, is what advice, if any, do you have for others who might be considering adopting Mirasol platelets?
Well, I think it's a very easy procedure, and it has given us a lot of comfort in all those times, and mainly I think for the people that are repeatedly transfused, there is the big advantage. I think it's for patients, not our hematology patients, but the patients on other wards. There probably it's not a big difference, but it's mainly for hematological patients where you have transfusions repeatedly during long periods sometimes. We really see a very good evolution and very well tolerated.
Well, thank you very much for spending some time with us today. We appreciate your comments and what wonderful experience you've had.
Mm-hmm. Thank you.